This is Video History, the J. Bay Jacobs Library for the history of obstetrics and gynecology in America. And on a pleasant May afternoon in 1993 in Washington, D.C., my guest is Dr. Brooks Ranney of Yankton, South Dakota. Brooks, president of the college in 1982, and perhaps most renowned for clinical studies that he's carried out for extended periods of time. My pleasure to have you with me today.
It's a pleasure to be here.
Brooks, let's begin by having you tell me where you were born, which I'm sure is going to be in the Midwest, and trace your education until it was finished.
Well, you're taking a long chance there. I was born in Florida.
I never would have believed it.
Actually, I grew up in a small town in central Illinois called Metamora, near Pearse, and got my grade school and high school education there, and went to Oberlin College for 4 years, and then directly to Northwestern University Medical School for 4 years.
And those years were, if it's not too embarrassing to ask you?
I was in college from 32 to 36, and in medical school from 36 to 40. Interned at the old Wesley Hospital at 26th Street in Dearborn.
And then on the south side of Chicago.
For 1 year. And then I started out in a residency in obstetrics and gynecology at the University of Chicago, the first 3 months of which was at maternity center, Chicago Maternity Center. And then the next 3 months was at a place they called the euphemism was the Chicago Municipal Social Hygiene Clinic, which was primary
venereal disease, yes.
From which I learned a great deal that I used in the Army, because starting after about 7 months of residency, I was in the Army for almost 5 years. Overseas, 2 of those years in Europe.
Just to interrupt your continuity there for just a minute as we flow, I happen to know that you wrote a book about those experiences. Could you say a word about that while we're right there?
It's called the To Cross the River Barriers, and it's a story of the entire interval of the 181st Engineer Heavy Ponton Battalion, which is a heavy ponton battalion that crossed most of the major rivers in Europe during the war under combat conditions. So the Seine, the Meuse, the Rhine, 2 places, and Remagen, the Weser River, and so forth. And then I came back from that and walked down, I should say rode down from Sheridan, stopped at the new Wesley Hospital and asked if they had a residency there. That was September 27th, 1945. And they looked over my record, I guess, and figured that I could unravel the knots. They hadn't had a resident there for 3 or 4 years by that time. And
the new Wesley Hospital was at Superior and Fairbanks Court.
University. Right. Northwestern University Medical School. And I got a call the next morning, could I come to work the 1st of October?
Residency applications were a little simpler in those days.
So I was there for 3 years. Finished the residency in 48.
And your mentors then were?
George Gardner, Ronnie Green, John Brewer. I could mention a few more.
John Brewer himself, the president of the college in the relatively early years. It was a powerful faculty in those days.
That's relating to the college. John Brewer gave the presidential address of the Central Association, which changed the name from the academy to college. That was his subject. John Brewer also was a person who initiated the junior fellows. What he did was start out a residence day every District 6 meeting. He was chairman of the district, and for 3 or 4 years we had residence day, and that gradually evolved into the junior fellowship.
Brooks, when you finished the residency in 1948, where did you go?
Well, I had a number of choices, several in Chicago and several in the East Coast and the West Coast and down in Texas, but I had a friend who was a resident named Ted Sadler, internal medicine. And he said, well, why don't you come out to my hometown? I'm going back there and practice with Chester McVeigh. Chester McVeigh is a surgeon who was a preceptor of mine in anatomy when I was a freshman medical student. So I knew right off the bat, if I went there, I'd be practicing with two grade A men.
Dr. McVeigh was, as I recall, a great hernia expert and worked with Barry Anson on anatomy textbooks.
He claimed he was a frustrated gynecologist. He did a lot of the pelvic anatomy and Curtis's anatomy in his textbook. Well, anyway, I finally made up my mind to go out there because I had the opportunity to practice full-time and to teach full-time, which was something you couldn't do even in those days, most places in the country. So I was immediately on the faculty at the University of South Dakota School of Medicine as an assistant professor, and as soon as my boards came along in 1951, I was a full professor and have been since then on the faculty at the University of South Dakota School of Medicine.
I calculate 1948 to be about 45 years ago. How many places have you been since you went to Yankton? Almost none. Is that about right?
Well, I've been to Yankton, and I've been to plenty of places for medical meetings, but...
Oh, my point, of course, being that you've really been practicing.
That's true.
45 years in one location.
I still see patients that I delivered or operated on 45 years ago.
Certainly, over the years, one of the things you've been best known for has been, of course, what you've been able to accomplish by being in practice in one place for 45 years. That is the opportunity to follow large numbers of patients, not only the patients, but their offspring with individual conditions and background over a very long period of time. Could you tell us about two or three of those most famous studies? Maybe perhaps your Pap smear study would be a place to start.
Well, the first, I'd rather give two background points.
Go right ahead.
One is that you have to keep proper records to be able to do these things. And by proper records, I mean card indexes. In these days, it would be a computer, but in those days, punch cards. To be able to find the things you want. And the second point is you have to figure out ahead of time what you might want to be looking for so that you have that.
Yes, the question. Right.
But if you do those two things, and if you practice over a long period of time, you find out things that can't be found out in any other way. My first interesting observation that I extended on into a study had to do with placentas.
Okay.
The fact that I noted in two or three patients on whom I had to do a manual removal of the placenta, that I found it to be way up in one corner of the uterus or the other, one horn or the other. And this got me to thinking, why did those placentas stay up there? And I thought that it probably was because the implanting so high, there was not enough shearing power behind the placentas to shear them off in the usual way if they were implanted on the anterior posterior wall there would be. And then the rest of the uterus just kept down around and tightened up on them, so they had to be removed manually. A little background information. It's necessary to realize that in those days, just before that, we didn't have antibiotics and we didn't have easy blood transfusions, and therefore nobody did any manual removals of the placenta except in emergencies. But we had, when I went out to Yankton at that time, we had blood transfusions and we had antibiotics, so we felt a little freer about examining the uterus. Well, along came a patient who had twins. And this patient's first baby delivered, both of them had first, easily. And then the second baby delivered, and the second baby's placenta delivered, and the first baby's placenta I had to remove manually about 20 minutes later. And I found it in the corneal uterus. And then I thought I really had figured out, I had a controlled experiment. So I kept track of all the patients who had manual removal of placenta, and I also did an experiment in which every patient that I delivered, as soon as the baby was delivered, somebody took care of the baby. I felt up in there to find out where the uterus was. Then, As soon as the placenta delivered, I figured out whether that placenta, how thick the wall of the uterus was under that placental site. And I measured those things as well as one can by palpation and determined that there is a great difference in the thickness of the uterine wall on the anterior or posterior placentas as compared to the corneal part. And I think that 75% of placental retention is caused by corneal implantation.
Just perhaps lead into some of the other studies. How many patients have you kept records on over these 45 years?
About 7,000 deliveries and about 6,000 operations, including minors. Yeah.
And,
I haven't kept track of the work in the office yet.
but it was sufficient, I'm sure. What other study or two would you like to tell us about today that's really been most important in your mind?
You may know that I was interested in endometriosis because I had a paper out on the etiology of endometriosis when I was a resident. As a matter of fact, it was part of my master's degree. And so I watched my patients carefully concerning endometriosis, kept good records on them, and wrote a paper concerning conservative operations for improvement of infertility in endometriosis patients. And during that time, it came to my attention that there were certain patients who avulsed one surface of endometriosis off another and bled internally and had hematoperitoneum, emergency operations. And all of these patients either had endogenous or exogenous progestational agents, either progesterone or progestational agents, which soften the endometriosis. And that's one of the reasons I wasn't very happy about using that method of therapy for endometriosis. That was the second paper. Then the third paper I wrote on complete operations for endometriosis. And while I was doing that, and this is what happens, and almost every time you do a study, you find out something else that you want to check up on.
Serendipity strikes.
Right. And the thing I found out on the third paper was that there was evidence that these patients with endometriosis were running in families. Now, this had been discussed in 2 or 3 other instances, but never very completely. But since then, Joe Lee Simpson and one of his cohorts and I have written a paper in this regard.
I think everybody remembers your paper about the familial tendency in endometriosis. So tell us a word about your studies in external version.
I had the first year in practice, I had a prima gravida that came in with a breech presentation. And it moved along to about 7.5 or 8 centimeters of dilatation and prolapsed cord. Now, she had an adequate pelvis, and I had a head stethoscope on, as I always did during deliveries. I was watching the heart tones, and when I noticed that they were slowing slightly, I decided I would have to deliver this baby through an incompletely dilated cervix, and I did, without any great trouble. But I made up my mind then that I was going to try to avoid as many breech deliveries as possible in the future. And we had been taught in medical school that external version was dangerous. This was based on the European studies in which they gave patients anesthesia and then did external versions and had ruptured the uteri or abruptio placenta. But I taught myself how to do external versions and reported on this to the Central Association some years later. And I divided those external versions into 4 groups of 4-year intervals. And it was obvious that experience made a lot of difference. But it got to the point where only, instead of getting somewhere between a 2.5% and 4% breach at the time of delivery, I had 0.5 of 1% breach at the time of delivery.
And certainly one thing many of us remember from the Central Association is Brooks Ranney striding up to the podium and reporting on 7,000 patients with X and how long they were followed up and the exciting things that happened.
I was quite busy in my early years, and I was alone as an obstetrician gynecologist. I know very well the meaning of the term, the buck stops here, because that's where it stopped.
Brooks, in our remaining minutes, tell me something about your career with college. How did you rise to be president?
Well, the first time that I was asked to do something nationally is not a matter of record, and I'll tell you a little about it. This was back in the early 50s, very early. The college had a committee on public education, and they wanted to find somebody who would write articles for the Ladies' Home Journal, I think it was. And there had been a writer who was writing articles concerning women in the Ladies' Home Journal, and he had retired, and they were looking for another person, and apparently they got in touch with the college committee. George Gardner was on that committee, and he knew that I had some capacity to put words behind and in front of each other, and so he recommended that they get in touch with me, and they did. And the editor asked me to write a couple of articles for them, and I wrote the articles, and they were accepted almost the way I wrote them. The problem arose, though, that the committee insisted that I use a nom de plume, and the editor wouldn't have it. Money didn't enter into this.
Well, because there was none involved, yes.
I was going to do it for nothing. But that's where it ended. But then I went on to become chairman of the Public Education Committee about the time that, well, it was about in the 50s. And I can recall very distinctly that Sprague Gardner and, one other.
I can't help you here.
Well, a senior member that was at the meeting here, they're not, well, it's
anyway.
They were very courteous about giving me some hints about how to run the committee when I first started out.
And what led you on the path to being president then?
Well,
I recall service on commissions and...
I was, of course, section chairman for South Dakota, district chairman for District 6. I was the first commissioner for practice at the same time that Harold Kamenetsky was the first commissioner
of education. Mm-hmm. In the early 70s, right?
And then I became vice president in 78, something like that, or 79. My first meeting with the executive board when I was chairman was back in the days when Clyde Randall was president. That's how far back I go in the executive board.
And what were the highlights of your presidential year in 1982?
Well, I think that it was a year in which I learned a great deal about obstetrics and gynecology all over the United States because I spent at least a third of my 3 years before president and after president and during the president year traveling around various places trying to find out what they needed to know about. And my presidential address included 10 of these basic items. One of the things that bothered us greatly at that time, and still does, of course, is medical liability and the tragedy that it has, tragic effect it has.
Well, we well remember your presidential year. Indeed, we well remember you, Dr. Brooks Ranney, a distinguished clinician, a careful record keeper, a well-known clinical investigator, and a genuine great person.
Well, thank you.
Good to talk to you.